right, and welcome to the third and final lecture within our farm class. So the previous two were chapter 23, I believe chapter 25, and then this is chapter 28. And originally it was meant to be one class, one lecture, and I broke it down into three just for the sake of focusing in on specific concepts in a more clear and more focused manner rather than to try to just throw everything in and cover everything. That would have been actually impossible. So this will be the third and last of the three chapters that you should be reading, should have already read. So let's jump right on into it. So, well, obviously, we're talking about diuretics, not only the drugs, but a few of other things as well. But mostly the drugs is what we're going to want to learn here and focus on. So that said, what is a diuretic? A diuretic is a stimulant. That's what a diuretic is. And it doesn't matter if the diuretic is an herb, if it's a supplement that works as a diuretic, if it's watermelon or parsley or dandelion root, or hydrochlorothiazide, potassium sparing. It doesn't matter. A diuretic is a diuretic. There are some are natural, some are pharmaceutical based. When you work in the acute and critical care setting, obviously with patients that are pretty ill, we're not going to be giving any of the upstream sort of natural approaches to that. We're not going to be giving them a glass of watermelon, although it probably wouldn't hurt if they had that as well. We're going to be focusing on how to get that water out of their body, how to bring their blood pressure down, how to stabilize them first and foremost. And for this, there's nothing better than pharmaceuticals and the medications and the drugs that are available in the hospital. So a diuretic as a stimulant, what it does is it basically pushes or expels it. It stimulates the kidney as a stimulant. It stimulates the kidney to get rid of water, right? And it can do it in a variety in different ways, right? By holding on to salt will keep the water in. By allowing salt to go out will help the water move outward. And so that's the kind of thing that we want to focus on in this lecture is the drugs that we give, what part of the nephron, loop of Henle, the proximal tubules, do the drugs work on and what their action is. On top of what indication, what do we use each drug for, and then what do we need to be careful and watch out with, both side effects and adverse effects that may come with the drug. So in a nutshell, that's what we want to learn is the drugs, their names, what classification they fall under, what we use them for, and what we have to watch out for as well. And since we know that diuretics are stimulants, well, there's all kinds of stimulants. There's marshmallow root up at the top left. There is dandelion root at the bottom right. And then the top right and the bottom left, both of those are juniper berries. And all of these are natural forms of stimulating the kidneys to get rid of the water in a natural substance. Now, I do want to make something quite clear here. Again, for your average, relatively healthy person, definitely with no chronic kidney disease or that doesn't have renal failure, they just may have some history of hypertension, and it's a better route to go is to try to use some of the natural things. But once somebody starts to have kidney problems, we have to be very, very careful with what herbs and supplements they're taking because it can put them at pretty high risk. Remember, one of the big problems with the people that are on dialysis is they're unable to filter things out. And so one of the big things that ends up happening is their potassium levels shoot really, really high, and sometimes we end up having to do dialysis a lot sooner, a lot earlier than their scheduled date because they have a potassium of 6.8 or a potassium of 7.2. And we know that can put their heart at risk for a lot of the arrhythmias and dysrhythmias that we know a little bit about from the previous lecture. So one thing that I do want to say with patients that are having kidney problems, of all the patients we're going to be seeing as healthcare professionals or providers, supplements, nutrients, herbs are actually with these are the patients we want to be most careful with suggesting that they take or consume any natural substance. Ideally, they'll work with their primary doctor or nephrologist that does understand these natural forms. But we have to be very, very careful with patients who are already in chronic kidney failure, or especially the ones that are on dialysis, suggesting any of these things, because they're already taking a lot of medications, and the interactions that natural substances could have on these patients could be deadly. And so I do need to forewarn you with this knowledge and understanding. So one thing I want to cover before we get into the drugs is I want to ask you what kidney function is. Does anybody know what the function of the kidney is, right? Well, filtering, okay. Good. If you thought about filtration, that's the good start, because kidney function really is referring to the kidney's ability to filter, and only this. When we say kidney function, we're talking about the kidney's ability to filter. And the kidneys really are of all the organs, they're probably one of the most misunderstood, because a lot of times patients, and this is why herbs and supplements and things like that are risky with this group of population that have CKD or chronic kidney disease or are on dialysis, because and even patients who are not yet in chronic kidney failure, a lot of time patients often will fail to grasp or understand how the seriousness of their condition, and that because they don't have that proper understanding, they can't take the appropriate steps to prevent or ameliorate or make sure that their kidneys don't continue getting damaged. A lot of times they go asymptomatic up until their kidneys are gone for 80–90% of the time. And then at that point, it becomes really, really tough, if not almost impossible, to reverse. And so part of the reason for this is the very nature of the kidney disease in itself, right? And most of the damage of the kidney disease has already taken place by the time a lot of the patients are becoming aware. Now, I want you to pay close attention to this, right? The kidneys do have many functions, right? And we know that filtration is one of them. But we talk about they regulate blood pressure, they regulate the pH, because remember, kidneys and lungs. Lungs, the CO2, which is acid, kidneys, the bicarb, which is the alkaline, right? So they do regulate the pH. But in terms of kidney function, I want to make this very clear. Kidney function is not referring to anything other than the ability of the kidneys to filter out uremic wastes. So a patient could have a kidney problem, nephrotic syndrome, polycystic kidney, chronic kidney infection, you name it. And these conditions are serious, right? But if their kidney maintains the ability to filter the wastes, the uremic wastes, and they haven't been compromised, they have 100% of their kidney function. So they could have nephrotic syndrome or polycystic kidney disease or chronic kidney infection. But if they have 100% of their kidney function, if they are able to filter 100%, they don't have, their kidney function is intact, because what we're looking at is only their ability to filter, not the fact that they have a disease. Now, that said, I will say that, and knowing what the kidney function is, which is the ability to filter, what type of organ would you say the kidney is? And I'll give you a clue. Sometimes we tend to focus a little bit too much on the word filter, and we forget to ask, what do the kidneys filter? And I mentioned it previously, just like a minute ago, uremic wastes. The kidneys filter out uremic wastes. And that means that the kidneys are an organ of excretion. I personally prefer to call them vital organs of detoxification, but in the nursing world and allopathic world, we don't use the word detoxification. We use the word excretion, filtering and excretion, but really it's to get rid of a lot of the wastes, because we know that renal nitrogen metabolism, it really is involved with urea, ammonia, the metabolism, and what do we call these wastes? We call them nitrogenous or nitrogen wastes. And what are the nitrogen wastes? The most common one are the uremic wastes, but there's ammonia buildup, which could happen. There's urea, there's uric acid, and there's creatinine. And we measure creatinine in the blood. We measure creatinine clearance in the kidneys as well. Sometimes we just do the GFR, glomerular filtration rate, to see how they're doing. Other times we'll do a creatinine clearance. For drug purposes, most pharmacies still go through with the creatinine clearance. And all of these substances are produced through the protein metabolism. So that said, remember, kidney functions refers only to the ability of the kidneys to filter. and that the kidneys filter mostly uremic or nitrogenous wastes, and we can consider it an organ of excretion, or as I prefer to call it, an organ of detoxification. A second point before we get into the drugs that I want to make very, very clear, because it's a very, very common misunderstanding. There is no such thing as stage 3 kidney failure, stage 4 kidney failure. There's chronic kidney disease that has up to 5 stages, and only stage 5 is kidney failure. So if they have chronic disease stage 2 or chronic kidney disease stage 3 or stage 4, all they have is chronic kidney disease. I mean, it's a serious chronic kidney disease when they're at stage 4 because they're right next to going into kidney failure. And I have a couple slides later that will show you the percentages. But so if chronic kidney disease continues to progress, it ultimately will lead to kidney failure. And kidney failure is basically, remember what the purpose of the kidneys is, to filter, right? So kidney failure is the state of the kidney in which it cannot, or it's lost the ability to filter uremic wastes to the point where, you know, life-saving measures are necessary at least. So if creatinine is normal or just mildly elevated, even if they have chronic kidney disease stage 4, if their creatinine is normal or just mildly elevated, the patient is not in kidney failure. Do not use the word kidney failure lightly, okay? There's a huge difference. And again, the most common measurement we use again for kidney function is the eGFR, or the estimated glomerular filtration rate. Above 60 is where we want it to be, so the higher the better. 60 and above, normal kidneys. And this is often taken as what percentage out of the 100% of the abilities of the kidneys to filter. So if kidneys filter at 100%, wonderful. So GFR is looking at a percentage of a rate. So we can use the GFR to grade chronic kidney disease. Stage 5, which is kidney failure, is, you need to know this, GFR under 15. Above 60 is the normal GFR. Once you get a GFR below 15, they're in kidney failure or stage 5 chronic kidney failure, kidney disease. So again, I'm emphasizing this multiple times here. Chronic kidney disease is not the same as kidney failure. Kidney failure is the last stage of chronic kidney disease. And then the final slide to make this point again is you have stage 1 chronic kidney failure, stage 2 chronic kidney failure, stage 3, stage 4, and ultimately stage 5 is where it's below 15% of the normal kidney function, okay, of the normal kidney function. That's not looking necessarily right now. Anyways, we'll get into that shortly. Chronic kidney disease here again is the stages. Stage 1, basically slight damage to the kidneys. Stage 2, mild decrease in the function or the ability to filter. Stage 3, moderate. Stage 4 is severe decrease in the ability to filter. Stage 5 is kidney failure. So this is, in a nutshell, the types of diuretic drugs that are available to us to use. We can accelerate the rate of urine formation, so produce more urine to get it out quicker if they're still able, obviously, to urinate, to void. We can, and ultimately, the removal of sodium and water, because water is always going to follow sodium, right? And so diuretic drugs can be used because of this ability to remove the water to lower the blood pressure, because when you drop that vascular system, get rid of water, the blood pressure should come down naturally. Heart failure, a lot of times congestive heart failure ends up having buildup of fluid in there. The hallmark sign and symptom of heart failure is lower extremity edema, but you can also have congestive heart failure with fluid in the lungs, and we need to get rid of the fluid out of the lungs, and so we can use diuretics as well. Diuretics are also used in many other areas. If you're giving, for example, packed red blood cells to somebody who has heart failure, you just want them to get the benefits of the red blood cells, but not the fluid, then you would give the first unit of packed red blood cells, and in between you'd give a diuretic, and then you may give a second unit of packed red blood cells, depending on what the doctor's order or what the patient needs in their H&H levels. So there's a lot more than we can use the diuretics for, but we're focusing on the basics here. So remember sodium. Sodium is very important, and where within the kidney does sodium does the diuretic work is going to be important for you to remember. So in the nephron, remember, where sodium goes, water is going to follow. And 60 to 7% of sodium in water is returned to the bloodstream through the proximal tubule. That's very close to where the filtration process happens. 20 to 25% of all sodium is going to be reabsorbed in the bloodstream in the ascending loop. 5 to 10 is reabsorbed in the distal tubules, and 3% ultimately in the collecting duct. And a key thing to remember here is if water is not absorbed, it is going to be excreted as urine. Okay, so now let's look at what we're talking about. Remember what we just said. I'll go back. We have 60 to 70 in proximal, 20 to 25 in the ascending loop of Henle, 5 to 10 in the distal tubules, and only 3% in the collecting duct. So the vast majority is going to happen right where it says 1 and 2 in the proximal tubule. And if anything, keep coming back to this chart in this slide, because NCLEX likes to ask questions to see if you know where an osmotic diuretic or a CAI, also known as carbonic anhydrase inhibitor, which we'll talk about shortly. 1 and 2, the osmotic diuretics and the carbonic anhydrase inhibitors, which I'm going to call CAI from now on, they work right where the numbers 1 and 2 are, which is the proximal tubule. So if I were to ask you, where do the loop diuretics work? In the ascending loop of Henle, where number 3 is. If I ask you, where do the thiazide diuretics work? They're going to be in the distal tubule. They're not proximal to the glomerulus, they're distal to the glomerulus. Proximal means close to the glomerulus, distal means further away from the glomerulus. And then the potassium sparing diuretics are also working in the distal tubule as well. And then a very, very, very small amount will be in the collecting duct. So keep that in mind, because that's important for you guys to know. So which location is the area where the highest percentage of sodium in water is reabsorbed back into the bloodstream? And remembering what we said, right? What did we say? Where did the largest percent, if 3% is at the end, and maybe 10 to 15 is at the distal, and then the higher amount is going to be right closer to the glomerulus. It's going to be proximal to the glomerulus, then think proximal tubule. And the proximal tubule, or is right after the glomerulus, and 60 to 70% of the sodium in the water that's filtered through the glomerulus are going to be filtered back into the bloodstream right after the glomerular. So let's go back. You have the afferent and the afferent going into where the glomerulus is. Glomerulus is where filters it into the actual nephron. And 60 to 70% of, again, let me repeat it, 60 to 70% of the sodium and water that's filtered through the glomerulus are going to be brought right back into the blood, right where it says number 1 and 2 in the proximal tubule. Okay, so the answer is B to that question. So here in a nutshell is the types of diuretic drugs. We have CAIs, we have loop diuretics, we have osmotics, we have potassium sparing, we have thiazide or thiazide-like diuretic. That's it. There's not much to it. So let's jump right in and cover these one by one. We'll start with the CAIs. The most commonly used one is carbonic anhydrase inhibitor, also known as Diamox, and it's used as a diuretic. Some people call it a water pill. I like to ask patients to, because if they're changed from one water pill to another, and all they know is it's a water pill, they may not have been properly educated on how it works or some of the risks, because one water pill may be very different from another water pill. So I generally suggest patients to not use the word water pill. And Diamox is used as a diuretic in people with congestive heart failure. And what it does is it helps reduce the buildup of fluid in the body. And what is that buildup that we're trying to prevent? Edema. That's the buildup we're trying to prevent. So Diamox also can be used to treat seizures and altitude sickness and quite a few other things. But for the most part, it prevents edema or buildup of fluid, and it's used for most commonly for what condition? CHF. Keep that in mind. Okay. So mechanism of action, I should have highlighted that. Mechanism of action. How does the CAI work? It helps to make hydrogen ions available for an exchange with the sodium and water. And that again happens where? At the proximal tubules. And the CAIs are gonna, this is where we really need to know here, is they block the action of carbonic anhydrase, preventing the exchange of hydrogen ions with sodium and water. And by doing that, by blocking the action of carbonic anhydrase, they do what we know that CAIs do, which is prevent buildup of water and prevent edema from happening, especially in CHF patients, okay, congestive heart failure patients. Further mechanism of action talks about, again, inhibition of the carbonic anhydrase, right? And that, which we talked about on the previous slide, but this slide you want to understand is that as a result of inhibiting the carbonic anhydrase, what happens? There's an increased excretion in bicarb, sodium, water, and potassium. And ultimately, reabsorption of water is going to be decreased in the proximal tubule, and urine volume is going to be increased. Especially the urine volume increased is a good thing when you consider that edema or third spacing or fluid in the lungs, we want to get that water out of the legs, out of the third spacing, out of the lungs, into and through, and to increase the amount of urine volume to then be able to, if they still have an ability to filter, then with that urine volume increase, we can get it out. Where you don't want the fluid is in the lungs or in the third spacing in the legs in the form of edema. Indications, I should have highlighted that in red as well. So what do we use CAIs for? Well, it's used also for open angle glaucoma, long term. It's used with miotics to lower the pressure, right, of the glaucoma before ocular surgery in some cases. And it's also used to treat, I already mentioned this, to treat edema and high altitude sickness. And we understand how it does that now through the mechanisms of inhibiting that hydrogen and that carbonic anhydrase. Now, this I did highlight as an important thing to understand because there are some contraindication. Obviously, if they're allergic to it, don't give it to them, please. A lot of times if they don't have an allergy and they have it the first time, then we need to make sure we put into the system that they're allergic to CAIs, and so that when we discharge them, they may go home with a different form of quote-unquote water pill or a diuretic, and their primary doctor can be notified when they do the medication reconciliation. Another few contraindications, if they have low sodium and low potassium, hyponatremia and hypokalemia, don't give them a CAI. If they have severe renal or liver hepatic dysfunction, don't give it to them. If they have adrenal gland insufficiency, which in many cases it's hard to know unless doctors are actually looking for it, or again, cirrhosis and hepatic dysfunction sort of go hand in hand. Liver problem, severe liver problem, hepatic dysfunction, inability to use the liver to detoxify the body, do not give a CAI. Hopefully I made that clear. Adverse effects of taking a CAI: acidosis, drop of potassium, drowsiness, anorexia, paresthesia, hematuria, urticaria, photosensitivity, and blood in the stool. So there's quite a few things that we need to be very careful with. And so if your patient is septic, or you're by any chance measuring lactate and they have high levels, so make sure we wouldn't be giving it, and then make sure we're always checking for potassium as well, okay, before giving a CAI. All right. And then interactions that may happen if a patient is taking a CAI, because it can cause a drop in potassium, an increase in digoxin toxicity may happen. So if they're on the medication, the cardiac medication digoxin, be very, very careful and make sure that potassium is replaced. If they're using corticosteroids, it can drop their potassium as well. If they take amphetamines, carbamazepine, cyclosporin, phenytoin, a lot of those are seizure meds, quinidine, which is we talked about in our dysrhythmia class, with concurrent use of CAIs, you have to be very careful because they can increase the effect. So if they're taking a CAI and they're on any type of amphetamine, some are for weight loss or some of the seizure medications, be careful because it can increase the activity or the. So with quinidine, what we need to remember is that if they're on a CAI as well, it could really prolong their QT interval. So we have to be careful with things of that nature. Loop diuretics. So here we're going into each class. We just talked about the CAIs. Now we're going into a different class. Now we're changing and moving out of the CAIs. We're moving into loop diuretics. And there's quite a few, but the ones that we really want to focus on are these, mostly Bumix and Lasix, but as well Edicrin or Edicin and Demodex as well. But you'll see Bumix and Lasix or furosemide or bumetanide used a lot within the outpatient and inpatient setting as well. So how do loop diuretics work? Well, they work on the loop, right? Usually, as we saw at that image, usually the ascending, which you should have remembered. And then the mechanism is for kidneys, for heart, and for some of the metabolic problems as well. They act on the ascending part of the loop of Henle, and what they do is they inhibit chloride and sodium resorption or reabsorption into the blood. Remember, if you prevent sodium from coming in, that means sodium is going to go out, and wherever sodium goes, water goes. So this isn't working directly on increasing the amount of urine, like what drug does? CAIs. Yes, you got it. This one is not saying, well, let's try to increase the amount of production of or volume of urine. Let's simply try to not keep sodium, not allow sodium to be reabsorbed. So let's block those channels, make sure sodium isn't reabsorbed. Water is going to go out anyways. They also increase renal prostaglandins, which ultimately dilate the blood vessels and reduce peripheral vascular resistance because of that vasodilation. Likewise, prostaglandin in the lungs also dilate and help breathing better, right? So it's very in a similar way, right? They just in this case, as opposed to lung prostaglandins, which dilate the blood vessels of the lung, they bronchodilate, allowing for breathing to happen. In this case, they're doing a dilation of the blood vessels in the kidneys, which reduce the peripheral vascular resistance. In other words, they can help the heart as well. And they're also useful in the treatment of edema as well. The drug effects of the loop diuretics, they're very strong diuretics, and they're strong in eliminating fluid. So because they're potent diuresis, you could lose a lot of fluid. So we have to be careful with quite a few things. The blood pressure could drop, patient could get dizzy, it could have fall risks, certain things of that nature. We have to be very careful, especially with the loop diuretics. But the decreased fluid volume will cause a reduction in. So as a strong diuretic and significant loss of fluid, we have to watch out for their blood pressure, their pulmonary vascular resistance, their systemic vascular resistance, their CVP or central venous pressure, and even their left ventricular and diastolic pressure. All of these are going to be affected, including cardiac output and ultimately potassium and sodium depletion. There's more than just potassium and sodium depletion, but the last comment on potassium and sodium depletion is significant because that means that with loop diuretics, we want to make sure we're monitoring their potassium and their sodium, because if we're giving it to them and they're already depleted on sodium, let's say you're in a neurological floor and a patient has very low sodium and you're getting ready to give them a loop diuretic. You have to be very careful in these situations because you could make their neurological condition significantly worse, if not dangerously deadly, if you give a loop diuretic. So we have to think that loop diuretics can be dangerous in certain types of patients. A lot of it has to do with how they will affect their vital signs, but also their electrolytes as well. Who do we want to give loop diuretics to? Well, edema, especially if it's associated with heart failure, liver, or renal problems. So in this case, if they have liver problems, loop diuretics are probably safer than the previous medication we talked about, which is a big no-no, the CAIs. We can give loop diuretics to control blood pressure or increase or hypertension, increase in blood pressure. We give it to increase renal excretion of calcium, just like there are drugs that are calcium channel blockers. We can give a loop diuretic to increase the excretion of that free-flowing calcium in the patient. So we have to watch out with that as well. We have to monitor their calcium. But in patients that are dangerously in hypercalcemia, they'll be given loop diuretics to try to push that calcium out sooner and quicker. And in cases of heart failure that result from diastolic dysfunction as well, we will give them loop diuretics. So those are the people or the patients that you're going to see that will be on loop diuretics. So adverse effects, I should have highlighted that in red because they're important to know. In the central nervous system, again, dizziness, headache, tinnitus, blurred vision. The GI, a lot of medications cause nausea, vomiting, diarrhea. Skin, we have to watch out because it could cause Stevens-Johnson syndrome. So if they're starting to get red and have what sometimes looks like an allergic reaction, just be careful. It could be Stevens-Johnson's. It's not that common, but we have to know that it happens. In the blood, it can lead to neutropenia, thrombocytopenia, or agranulocytosis. So we need to be monitoring their labs as well to make sure that they're not going into those adverse effects. Metabolically, again, it could shoot their sugars up. It could lead them to having more of the uremic wastes as well, and also drop their potassium. So we do have to watch out with loop diuretics for these situations. And in terms of interaction, they can be nephrotoxic, and they can be neurotoxic. They can increase serum levels of uric acid, which is what we just talked about in the previous slide. I'll go back right there. Hyperuricemia, metabolic hyperuricemia, right? So it increases the serum levels of uric acid. Glucose, so people with diabetes, we have to watch out. Some of the aminotransferases as well, and the aspartate aminotransferases. If the doctors are monitoring for these things, we want to make sure that they're not already high before we give them. And then thiazide, it can interact with affecting the nephron blockade. So with thiazide, we have to watch out when giving them together for multiple reasons. So just keep in mind that if it's a loop diuretic, watch out with simultaneously giving a thiazide, and we'll cover that when we talk about thiazide. And then be careful again with the loop diuretics if they're on a non-steroidal anti-inflammatory medication, because those can damage the liver as well. And so even though this is generally safer for the liver than, for example, somebody who has severe liver dysfunction, we would definitely not want to give a CAI, but if we need to have some diuretic stimulant to help them for whatever condition they may be having, CHF, edema, hypertension, this would be the drug of choice, loop diuretic. Just know that loop diuretics still are nephrotoxic. They can still damage the kidney. So we want to monitor for those labs that we just talked about, and we want to make sure they're not taken with an NSAID, not taken with a thiazide. And furosemide is the most commonly used. Lasix, furosemide, you should be very familiar with this drug. You should be very familiar with this name, this category, and of all within the classification of loop diuretics, Lasix or furosemide is the one that you'll be using the most. And again, we use it for pulmonary edema, fluid buildup in the lungs, or edema that in the lower extremities that may be associated with heart failure. We use it for liver disease, even though it can cause liver damage. It's also used for nephrotic syndrome, for ascites, and for hypertension. We just have to make sure that we're monitoring the liver labs as well, on top of the electrolytes. So take a look at this and see if you can answer it. I'll let you read it for yourself while I take a sip here. And I haven't covered this one. And so that was kind of tricky. because the previous slide was saying be careful with taking it with Tylenol. And there are some risks with the Tylenol, but one of the most dangerous things to do is to be giving a loop diuretic with the patient that is taking any form of lithium. Lithium toxicity is a very dangerous thing that we want to avoid. More dangerous, for example, than with Tylenol, which a lot of times all the answers may be right, but which one is most right? And in this case, even though we know that Tylenol consumption together with it can be risky, we also need to remember that the loop diuretic is the drug that we give for patients that have liver problems as opposed to the CAI, for example. So that said, drug interactions with loop diuretics therapy, you have to be very, very careful. And so just keep that in mind. Do not give loop diuretics with lithium unless the doctors want it and order it and say that it's okay. Make sure you call the doctor up and say, hey, you sure you want me to give a loop diuretic? They're on lithium. Yeah, we're monitoring. Just be careful that he doesn't or she doesn't go into lithium toxicity, which you'll get in a different class. So now we're changing to a different type of diuretic or stimulant. And the stimulant or the diuretic we're talking about is osmotic. And there's a few different types of osmotic diuretics. Mannitol is the most commonly used ones, but glucose functions as it, organic acids, urea, all of them have effects of osmotic stimulation in the body. So how do osmotic diuretics work? Well, we know they work in the proximal tubule for the most part. Non-absorbable, producing an osmotic effect, so they have an effect of osmosis. They pull water into the renal tubules from the surrounding tissues, inhibit tubular reabsorption of water, right, and solutes, thus producing a rapid diuresis. And that's important to know, rapid diuresis, okay? Keep that in mind. So they get rid of, they inhibit the reabsorption of water. So the CAIs may try to help produce more of that urine to pull it out of this third spacing, right? The loop diuretics are going to prevent sodium from being reabsorbed, and the water is going to follow that out. In this case, what osmotic diuretics are doing is they're inhibiting reabsorption of water and solutes, both of them, which helps with the rapid diuresis. They're pulling water out of the nephron to eliminate it quickly. Okay, and that rapid diuresis is very important to keep in mind. And the drug effects is they increase glomerular filtration rate and renal plasma flow, which help prevent kidney damage during an acute renal failure. We're not going to talk about acute renal failure. That's a whole class in itself that you'll get in third semester. Pre-renal, intrarenal, and post-renal failure. Those are the three types of acute renal failure that you'll end up having to know. Not something you need to focus here. What here you need to understand is what's happening in terms of osmosis. Mannitol, remember this, NCLEX and we in Los Medanos love to ask this question. Mannitol reduces intracranial pressure or cerebral edema. So if a patient comes in, they have head trauma, and they're remember, swelling in your arm is okay to a degree, or in your leg is okay because it can grow and grow and grow and grow. There's nothing holding it back. But when swelling happens in the brain, there's no space for that swelling to grow more. You have a skull, you have a bone surrounding the brain, and any pressure or any buildup of edema in the brain is ultimately going to cause death, literally death. So we have to be very careful. So we need a very rapid osmotic diuretic, and the osmotic diuretic of choice to decrease intracranial pressure, also known as ICP, is mannitol. It also can help to reduce excessive intraocular pressure as well. So who's going to be getting the mannitol or an osmotic diuretic? Patients in the early or oliguric phase of acute renal failure. So remember that. Patients that we need to get rid of certain toxic substances. Again, that ties back into rapid diuresis. If they have a toxic substance that we need to get out of the system, we don't want to give something that's slower, but a quicker, right? And then it helps reduce intracranial pressure, and it treats cerebral edema, which sort of goes hand in hand to reducing intracranial pressure. All right. Adverse effects that can happen. We do have to be careful with mannitol because it can lead to pulmonary congestion and convulsions, also thrombophlebitis, and so we need to monitor the patient for a lot of these conditions. We need to make sure we're listening to their lungs. We need to make sure they don't end up having seizures, especially in the neurological or the ICU setting. How do we give this big, important osmotic diuretic called mannitol? IV and only IV. We have to watch out that it does not crystallize when it's exposed to low temperature, and we always have to use a filter when we give mannitol. So you need to know these three things. You need to know that mannitol is an osmotic diuretic. It's a rapid-acting osmotic diuretic. It's given IV only. If you see crystal buildup or a change of color, throw it away, get a new one, and you always want to use a filter when giving it to the patient. So, that said, while you're preparing an infusion for a mannitol, the nurse notices small crystals in the IV tubing. The most appropriate action by the nurse is to, if you choose administer, wrong, right? We do want to obtain a filter, but look at what it says there. And then infuse. If you choose infuse, wrong. Return the fluid to the IV bag to dissolve the crystals. Don't do that. We want to discard the solution and get another bag. Once it's crystallized, it's not going back. All right, so we're now moving into a new type of stimulant, which is what diuretics are. They're stimulants. And this is a potassium sparing. And you need to understand that all of these here, Midamor, Diurenium, or any of the aldosterone inhibiting diuretics, spironolactone or aldactone, that is the most common one that we like to ask, that NCLEX likes to ask. But you could see any of the others as well. But what you need to know about these four is all four are potassium sparing, right? So they do not need to necessarily be on a potassium supplement, especially if they have any type of renal failure, because you could be pushing them into hyperkalemia, the opposite of what we want to happen with the patient who has kidney failure, okay? So watch out. With most diuretics, our biggest concern is hypokalemia, low potassium, because most diuretics are going to deplete potassium. With potassium-sparing diuretics, it means it spares it. It's not going to eliminate it, okay? So keep that in mind. How do they work? They work in the collecting ducts and the distal area of the tubules. They interfere with sodium-potassium exchange, that pump that we talked about in our arrhythmia class. They bind to aldosterone receptors. They block, and this is where we really want to focus in terms of its mechanism, they block resorption of sodium in water, which is usually induced by aldosterone. Okay, aldosterone will induce the reabsorption, so it's working on that RAS system, RAAS, to block the reabsorption of sodium in water. So very similar to a previous drug that we talked about. Okay, and then in terms of the drug effects of potassium-sparing diuretics, they prevent potassium from being pumped into the tubule. They prevent its secretion. I just talked about how important that is. Because they prevent secretion of potassium, it means it keeps the potassium in. It helps. It's not going to deplete the potassium. We want to watch out that our renal patients don't end up having hyper or too much kalemia or too much potassium. They competitively block aldosterone receptors and inhibit their action, as we mentioned earlier, and thus they promote the excretion of sodium in water. But they promote the excretion by, as we said on the previous chart, preventing their reabsorption through their inhibition action on the aldosterone receptors. Who is going to be getting a potassium-sparing diuretic, such as spironolactone or aldactone or triamterene, or the spironolactone and triamterene specifically, people who have high blood pressure, people who have hyperaldosteronism. So if their aldosterone level is constantly high, they may be getting it. Anybody reversing potassium loss caused by potassium. So if they've been on loop diuretics or if their potassium is really low and we need to give them a diuretic or a stimulant to help decrease the fluid buildup, then we're going to give them this medication here if they already are low on potassium. We obviously would want to replace their potassium, right? But we may need to change the type of stimulant that won't deplete their potassium as well as replacing it. Okay, and also patients that have heart failure as well to prevent the remodeling of the heart, which you'll get in third or fourth semester. And then the other potassium-sparing diuretic, amiloride, which is similar to the ones we just talked about, spironolactone and triamterene, is less effective in the long term. So they may be given short term, but they probably will be put on triamterene or spironolactone if they're going home with it, or if they have to take a potassium-sparing diuretic in the long run. They won't be put on amiloride. That's the main thing to understand about amiloride. Adverse effects of the potassium sparing are very similar to the previous ones. Dizziness, headache, so watch out with fall risk, cramps, nausea, vomiting, diarrhea, possible with the GI, urinary frequency weakness, or hypokalemia. I already mentioned hypokalemia previously. You need to be aware of that. And other adverse effects that might happen is gynecomastia, amenorrhea, irregular menses, postmenopausal bleeding. So watch out with women that are amenorrheic and have irregular menstruation. Also in men, it might produce enlarged breast, which a lot of men don't like, so they may need to be changed or may request at some point to talk to their primary doctor. Hey, I'm getting larger breasts than normal. Is there anything I can do to not have that happen? And interaction with potassium-sparing diuretic. Lithium, again, lithium. We need to watch out for lithium toxicity, okay? We need to watch out for lithium toxicity. Patients who are on ACE inhibitors for blood pressure usually, we have to watch out. And patients who are taking potassium supplements, we have to be careful with. And again, patients who are NSAIDs. A new form of diuretic, a different type, we're leaving the potassium sparing and we're coming into the last, I believe, form of diuretics that we're going to talk about. There may be a miscellaneous one, but this is the last category, thiazide or thiazide-like diuretic. Hydrochlorothiazide or chlorothiazide are the two most common thiazides. And then there's a few others that we'll cover briefly, but most importantly here is the hydrochlorothiazide and the chlorothiazide, as we'll talk about. So both of these, whether they're the thiazide or the thiazide-like, their mechanisms are similar. They inhibit tubular reabsorption of sodium, chloride, and potassium, right? So because they inhibit the reabsorption, we have to watch out that they don't go too low in sodium, too low in chloride, too low in potassium. They add their actions primarily in the distal convoluted tubule. The end result of the mechanism of action of these thiazide or thiazide-like drugs is water, sodium, and chloride are going to be excreted, thus water will follow. Potassium is also going to be excreted to a lesser extent perhaps than a few of the others. Nonetheless, still it excretes it, and it dilates the arterioles by direct relaxation. So that has a very, very good use and purpose, like the drug effect. It can lower peripheral vascular resistance. In patients that have heart problems, that their heart is already compensating, cardiomegaly, ventricular hypertrophy, if they're at a stage where they need to have their peripheral vascular resistance lowered, this would be a good option. It also depletes sodium and water and potassium as well for those who have water buildup, which is the whole talk about the diuretics in the first place. The one key thing that you need to understand, and actually I should start off by saying creatinine, does anybody remember what the normal creatinine is? Well, it differs for men and women. I believe for somebody who's relatively healthy, if you're a female, I don't know, 95 to about 100 for a woman, and for a male, it's about 120 to 125 milliliters per liter. For men, all right? And so when you keep that in mind, so anywhere between 95 to 125, right, for men and women combined. But if your patient has a creatinine clearance that's less than 30 to 50 milliliters per minute, as opposed to the 95 to 125, do not give thiazides. Memorize that, learn that, okay? If they're in renal failure or chronic kidney disease or stage 5 kidney failure, we want to make sure that we're measuring their creatinine clearance, that we're looking at what level it's at, and if they're less than 30 to 50, do not give. The one thiazide that is or can be given for patients that have a very low creatinine clearance of even up to 10 is metolazone. And remember, what is creatinine? It's basically a breakdown of creatinine phosphate from what? From muscle protein metabolism. Remember the nitrogenous wastes. Uremic acid is one, ammonia is another, creatinine is another one, and it's released at a constant rate by the body. And so if their kidneys have to be able to process it properly in order for us to be giving certain medications, like this one right here. And the amount of the blood, so creatinine clearance is nothing but the amount of blood cleaned of that creatinine by your kidneys. So how much are your kidneys able to clear or filter through or clean the blood of creatinine? Remember, creatinine is a waste, one of the nitrogenous wastes from the protein metabolism, and we need to keep that in mind. So we have to be very careful with thiazide and thiazide-like diuretics, and only one of them would we be really using if their creatinine clearance is very low. Now, in somebody who's in the normal range, 95 to 100, 120 to 125, these wouldn't be an issue. So who's going to get it? What are the indications? Well, when it's used mostly for patients who have hypertension. Hydrochlorothiazide, thiazide-like drugs are used, chlorothiazide are used for hypertension, right? It's used for patients who are in edematous state. It's used for patients who have hypercalciuria as well. It's used for patients who have diabetes insipidus. Now, don't make the mistake and assume that thiazides or thiazide-like drugs are used for patients who have diabetes mellitus. It's not for diabetes mellitus type 1 or diabetes mellitus type 2. It's for diabetes insipidus. Okay, not diabetes that we commonly know as diabetes. And diabetes insipidus is pretty rare, or not rare, but uncommon problem that really just causes an imbalance in fluids in the body. And one of the biggest things that happens a lot of the neurological floors, and one of the big things to keep in mind, which you'll learn in third and fourth semester, is that diabetes insipidus, that this imbalance is going to make your patient really, really thirsty. Even if you've had fluids, they drink fluids and they're like, I'm still thirsty. They drink fluids more and I'm still thirsty. They drink fluids more and I'm still thirsty. That's the type of diabetes we're talking about. So the thiazide diuretics are given for these type of patients. We have to watch out because there is some literature that shows that diabetes may increase the risk of diabetes because it lowers potassium. When your potassium goes down, you're at more risk for diabetes. And as long as we're monitoring potassium and sugar levels, they should be okay to be taking these, especially if they're replacing their potassium properly and their levels are normal. Should be okay with diabetic patients, but just make sure you monitor their diabetes. These drugs are also used for patients that have heart failure, especially caused by diastolic function. Or for adjunct drugs and treatments for edema, again related to heart failure, hepatic cirrhosis, or corticosteroid or estrogen therapy. They may be used together with a lot of those medications, as you'll see on some of the patients that are pretty critically or severely ill. Again, the adverse effects are very similar to a lot of the other diuretics. Dizziness, headache, blurred vision. So make sure you let them know they could be dizzy. Call, hit that call button. Don't fall. Blurred vision as well. Nausea, anorexia, vomiting, diarrhea. Genitourinary, a big one for men is impotence. And from a blood perspective, they could have leukopenia, or they could be yellow and have jaundice as well. Skin could get photosensitivity, they could get urticaria, and metabolically, again, high sugars, high uricemia, low potassium, and hypochloremic alkalosis as well. All right. So now most of the slides are going to be nursing implications. So you have to do a full head to toe. You have to make sure you assess their fluid volume, especially their intake and output. We got to make sure that they're able to produce urine in the first place. And then we're going to monitor their serum electrolyte values, which we've been talking about throughout. We're going to monitor their weight, vital signs, especially for orthostatic hypertension. We're going to be doing their postural blood pressure, laying, sitting, and standing, and assess for disorders that they may have, which would contraindicate any of the drugs that we just talked about. Make sure that we're not giving a drug to a patient who shouldn't be getting it. And then we need to instruct the patients to take the medication in the morning, because what happens with diuretics is if they take it at night, especially if they're a male who's above 40 who already wakes up to go to the bathroom 1 or 2 times because of prostate issue, if you take your diuretic at nighttime, that's just going to make you want to get up. It's going to interfere with your sleep pattern. We know that sleep is extremely important for the body to recuperate and heal properly. So good idea. Take your diuretics in the morning. Monitor serum, potassium, and much more than that, as I'll cover with the drug-induced nutrient depletion slide or chart that I'll go over shortly. Teach patients to make sure that they eat proper nutritional foods to replace their nutrients, the micronutrients, and drink fluid. Keep hydrated, right? Unless they have heart failure or fluid buildup, then there may be a need, which their doctor would determine, for them to have fluid restriction. But if they're not on fluid restriction, make sure that they keep well hydrated if they're able to void and urinate, obviously. And then teach patients to eat more potassium-rich foods, green leafy vegetables, when they're taking any of the diuretics except but the potassium-sparing diuretics. They need to still eat their potassium-rich foods as they have normally been, but not increase their amount of potassium-rich diuretics, foods, I mean. If they're on a potassium-sparing diuretic. If they're on a diuretic that gets rid of the potassium, we can say, hey, you may want to make sure you take a supplement, as well as trying to eat more potassium-rich foods. And then foods high in potassium include bananas, oranges, dates, apricots, raisins, milk, some people say, broccoli, green beans, potatoes, meats, fish, legumes. Those are things that you want them to eat. If they're in a chronic kidney stage 4 or stage 5, which is at that point kidney failure, we need to watch out with them eating these foods, because it'll build their potassium level up too high. So it's a balance. For your average patient going home on a diuretic that is going to deplete their potassium, we absolutely need to tell them to consume these foods, as well as taking a good multivitamin, multimineral, or including potassium, or a potassium pill in and of itself as well. Patients that are on diuretics with digitalis, we have to watch out for digitalis toxicity. Patients that have diabetes mellitus, if they're on a thiazide or a loop diuretic, should be told to watch their blood sugar a little bit more carefully, because as the slides that we covered, there were a couple slides, and I'm repeating it here again, the thiazide or the loop diuretics can lead them to have hyperglycemia. So just monitor their sugars a little bit more carefully. Teach patients to be careful for fall risk. That means watch out when you change your position. Do it slowly. Don't go from a lying to a standing position. Go from a lying to a sitting. Sit for a couple, 2 or 3 minutes. Allow that blood to get back to the brain. And then to prevent that dizziness from happening. And remember, diuretics are in most patients could lead to orthostatic hypotension, and in most cases we give them to drop their blood pressure. So they need to understand that if they're taking it for a reason that is not hypertension, we need to tell them, hey, these drugs, these diuretics are given for patients that have hypertension. So if we're giving it to you because you have congestive heart failure or fluid buildup or edema, right, but your blood pressure tends to be really normal or low, we just need to make sure that you have a way to measure your blood pressure at home, or that if you're in the hospital, that we're measuring their blood pressure before, or vital signs before we give them these medications. Make sure that they, especially those who have heart failure, congestive heart failure, in the hospital, will do daily weights every morning before the new nurses come on board, usually around 5 a.m. before the doctor hits the floor, because we want to know if they're accumulating weight, accumulating fluid. That's why we do daily weights. And then we also remind patients to return for follow-up visits to monitor their lab levels. Could be looking at their kidneys, could be looking at their liver, so on and so forth. Patients who have been ill with nausea, vomiting, diarrhea, watch out. They let them notify their primary care provider, because a lot of fluid and electrolyte balances are going to happen with diuretics. If that hasn't been made clear to you, then just understand that diuretics, these stimulants, these pharmaceutical stimulants, can lead to risky fluid and electrolyte imbalance. That's the whole goal, isn't it? To get rid of that fluid. But we have to watch out that that can cause problems of its own. Also, signs and symptoms of hypokalemia. What are they? Do you remember? Right? Because NCLEX isn't going to maybe tell you directly, oh, you have a patient who has kidney problems and he's on this drug, which is putting them at risk for hypokalemia. They may just simply tell you, you have a patient who's in here for heart problems. So they're trying to, distract you by saying they have a heart problem. They're not even telling you they have a kidney problem. They have a heart problem, right? But they may say some of the drugs that they're on are X, Y, or Z. One of them might be a diuretic, right? And if it's a diuretic that depletes potassium, not the potassium-sparing ones, but the one like loop diuretics and the others, then we need to know that the answer that they may be looking for is, are you aware of what that drug, they don't even mention potassium, they don't mention hypokalemia, they don't mention kidney disease. The patient is in there for heart problem, right? They're here for heart problem, but they're on a loop diuretic or on a CAI. Which one of these is most expected? Which one of these signs and symptoms would you most expect to see the patient? And maybe 3 of the answers, A, B, C, are related to the heart, and you're going to be thinking, oh God, heart, which one of these heart one is it? And only one of them says something like constipation, irregular pulse rate, or a feeling of lethargy. And you have to know and link in your own mind, in your own understanding, that that patient could be going through low potassium. So just keep that in mind and try to understand what I said. Go back and listen to that a few times, because that's an important concept to understand. All further nursing implications: to instruct the patient to notify their PCP immediately if they have rapid heart response, or syncope if they start falling, because it could be, again, hypotension or fluid loss. We have to make sure that we're not over-medicating them. So they need to talk to their doctor soon, quickly, about what they're taking and what's going on. Also, excessive consumption of licorice can lead to dropping their potassium as well, especially in patients that are on thiazides, because thiazides and licorice will potentiate the action of eliminating or not allowing that potassium to be reabsorbed. It'll eliminate it more. Monitor for adverse effects in many of these diuretics. We've talked about it: alkalosis, drowsiness, lethargy, hypokalemia, tachycardia, hypotension, leg cramps. There we go. Right, magnesium. Nowhere in any of these, I don't even think the textbook has mentioned magnesium. Shame on them, right? I mean, magnesium is one of them that is a big problem. Restlessness, and what was there something else that was there? I forget. That has to be decreased mental status, restlessness. So neurological changes. What do you think? I'm sorry that's not showing up. So right there, it should say restlessness and decreased. If I'm right, mental alertness so basically confusion. So why would a patient be getting confused or have decreased mental alertness? Sodium, okay? Shall I say that again? Sodium. People who have low sodium, we have to watch out. Also, we monitor for hyperkalemia in patients that are on potassium-sparing diuretics. If we haven't mentioned that a gazillion times, then shame on us. And again, as in everything, we always do an assessment before we have an action or we give a drug, then we give the drug, and then we evaluate and assess for did the drug work. Never give a diuretic, right? So if we know that they have fluid buildup in their lungs because we listened to their lungs and can hear fluid there, if we know they have edema because they have a +2 obvious edema, pitting edema maybe in their lower extremities, then we did our assessment, right? If they have high blood pressure, or if we know that they're having intraocular pressure and we want to lower those pressures down, or they normally take those medications at home and should be continued on them in the hospital, right? Then we've done our assessment before giving the diuretic. Then we would, after we assess for the edema or the fluid overload in the lungs or the legs or the hypertension, then we go ahead and we give the diuretic if it's called for, if it's in the MAR, or if they don't have a diuretic, we need to make sure we notify the doctors that they're having fluid overload or edema so that we can get in a medication for the patient that needs to maybe be on some form of diuretic while they're in the acute or critical care setting, because we want to get rid of that fluid in many cases, especially if they have cerebral edema. We need to notify that stat. Now, they may be monitoring for intracranial pressures, so there's a little bit more of a benefit there. You have numbers to determine if the pressure is building up, then we would order mannitol, right? And then after that, you would want to monitor for the ICP in the ICU, in the intracranial pressure. But for the general floor, we want to just go back and listen to their lungs again and look at their legs. And if they were at +2 pitting edema, maybe they're now at +1. Or maybe they have no pitting edema. They have just regular edema, but that's non-pitting. You see the point? The point is every time before we give a drug, we want to assess for the need for the drug. Then we may need to give the drug. We may hold the drug if our assessment says, oh no, he's hypotension, I don't think we want to give it. Or, oh no, he has liver problems, I don't think we want to give the CAI. You get the point? So you always want to do an assessment before you give the diuretic. Then you give the diuretic if it's called for. But you need to know, is it called for or not? If they have a very low blood pressure, you probably are not going to be giving that. And you need to find different ways to give it. If they're critically ill, you may need to give it to them and then give them some 250 bolus of fluids to replace that, because then we would drop their blood pressure even more. You see the point? The important thing is we need to pre-assess before we give any diuretic, and after, if it's called for and you do give it, after you give a diuretic, go back in and assess, did it have the therapeutic effects that we want it to have? That's what evaluation is all about. ADPI, the nursing process, it always starts with an assessment and ends with an evaluation. The implementation would be to give the diuretic, but make sure you've done an assessment to assess that there is a need for it. Make sure you've done an evaluation to assess for the therapeutic response. Has it been positive or not? Because if it's not, then we may need to do more interventions. We may need a stronger dose. Maybe we need more medications. Maybe we need the doctor to think about something else that might be going on with the patient. So I always emphasize therapeutic effects for your patient. All right, so we're done with all of the drugs. And now there's a series of 4 or 5 questions that I want us to focus on. And I'm going to let you read this while I take a sip of my tea here really quick. This is a tricky one because for the most part, I've been telling you mannitol is the rapid diuresis, but it's not that commonly used on too many of the med-surg floors. It's most commonly used for cerebral edema. It's used if really needed, but of the other, so it would not be an osmotic, although osmotic is the quickest to act. Which one it would be the next quickest would be the answer. And the answer to that is the one that has rapid diuresis because of the rapid onset of action. And as if you go back to the slide, that would be loop diuretic. So in a med-surg floor, right, we may not need to be giving mannitol, but we would need to be giving. You wouldn't want to give a potassium sparing. You wouldn't want to be giving a thiazide. Those are slower. A lot of those are outpatient. Patients take those at home. We want to be giving a loop diuretic, like through the IV. You could be giving Lasix through the IV, and that'll help bring it down quicker. Also, with that creatinine clearance, we have to watch out with a few of the other medications as well. And then because loop diuretics, you have to remember, they're effective for patients that have reduced kidney function. And we know that, creatinine kidney clearance below, let's say, 25 would be one of the ones, would be another reason for a loop diuretic to be given. And the patient is ordered for Lasix, right? Back to the previous question, the answer was a loop diuretic. So let's say we give them a loop diuretic. They're giving a Lasix. So before you administer furosemide, which is Lasix, before you give it the furosemide or the Lasix, it's important for the nurse to assess the patient for allergies to which class of drugs. And I don't think I commented on that, so this is something that you just need to know. And sulfonamide tend to be are the ones that we have to watch out. So the nurse should be assessing anybody before you give the Lasix. If they hey, do you have any allergies to sulfonamides? And if they say no, then it's okay to give. The next question is 2 days after admission, the nurse is reviewing lab for this patient. Which is the most common electrolyte finding that's going to happen from Lasix or furosemide? And you should know this one. This one I did emphasize significantly throughout. So if you've opted for potassium, you're absolutely right. We definitely need to monitor the potassium for various reasons, because we know that low potassium is of serious clinical importance as well. And to prevent that, they'll either get their potassium or they'll be given a potassium sparing supplement, diuretic, together with, or they'll stay on the Lasix. Just make sure that we replace their potassium. It is very important. Or before you give it, call the doctor up and say, hey, doc, I noticed that the potassium is low. Do we still want to give it? And then the doctor may say, yeah, go ahead and give them some IV potassium together with the med, or the doctor may want to try to change the medication. So the patient is now being discharged home with furosemide Lasix. When providing discharge instructions, what do we need to instruct the patients for? Well, with Lasix, we wouldn't want to tell them to not eat potassium, right? We need to be careful with telling them with stop taking the medication just if they're having dizziness. We do know that orthostatic hypotension is a possible adverse reaction of the patient, but they shouldn't stop taking their medication unless they consult with their healthcare provider first. So be careful with choosing any of the stop taking the medication. The only time you would ever want to opt for a stop a medication before consulting with the doctor would be if they're having an allergic reaction, if their breathing stopped, if it makes them bleed more, if it's at a risk for the patient, some pretty moderate to severe risk for the patient, stop the drug, then notify the doctor. Obviously want to do that. Not in this case. The patients should be weighing themselves once a day and report weight gain or loss of usually around 3 pounds, 3 to 5 pounds. So not so much 1 pound. We should encourage them to eat foods rich in potassium. So patients that take furosemide should avoid prolonged exposure to sun because of what? Photosensitivity. Remember we talked about photosensitivity? Yes, we did. So that was the answer to this one. I'm giving you some hints here. Now, I'm going to skip this slide here, go right into a couple of last few points here. There's only about 4 or 5 slides here left. Things that I wanted to talk about that are important is that there are some natural diuretics. Remember, diuretic is a stimulant. Watermelon is one of them. And watermelon, not only is it high in beta-carotene, folic acid, B5, B1, B2, B6, and vitamin C, has tremendous nutritional value, including zinc, iron, sodium, magnesium, potassium. And so it's good for your joints. I mean, this is coming from WebMD, mainly because it has a natural pigment called beta-cryptosanthin. It can protect your joints or inflammation. But because it's full of water, it gives you 92% of what a watermelon is water, but it's very high in potassium. But it also functions as a diuretic, mainly because of an amino acid that it has in it called citrulline, which will relax the blood vessels and keep fluids from leaking into the tissue, that sort of allowing it for it to be urinated out as opposed to third spacing. Thus, it reduces the retention of water. So one way to go, again, we have to be very careful with talking of these natural substances to patients who are already in some type of chronic kidney failure, and especially on patients who are on dialysis, because these are really complicated cases. They need to be really talking to their nephrologist about things that they should and shouldn't be consuming. But for your average patient who came in and they had a stent, they're on a hypertension, they may not have blood fluid buildup, they're relatively healthy. These are things we can be talking to them about because it'll help their blood pressure, it'll help it function as a diuresis as well. And remember, one of the side effects of a lot of these diuretics is I should have said this, God, at the beginning, I apologize. What is one of the side effects of a lot of the diuretics? Fluid. They're going to be dehydrated. So consuming watermelon is rehydrating them in a natural way by giving them hydration and diuresing them. And watermelon, like a lot of the berries, won't spike your blood sugar, so it won't cause that hyperglycemia. This is just to show you again, juniper berries, marshmallow root, and dandelion root as well are also known as common diuretics. Parsley, WebMD has indicated the only thing with parsley, like any green leafy vegetable, it's full of vitamin K, so you have to watch out with it. It assists in blood clotting, right? And it may decrease effectiveness of blood thinners or warfarin. But parsley is a natural diuretic. It works like a water pill by causing the body to lose water. So be careful if patients are already on water pills, that if they consume more parsley, obviously dizziness, drop in blood pressure, and do not take it with lithium at all. Okay. Long-term diuretic therapy is questionable. A lot of doctors will still keep their patients on it. That's again up to the doctor. It will drain the body of many important nutrients, minerals, including magnesium, which really we need to be aware of. Everybody just jumps on potassium, but it's much more than that. And so supplementation, a good multivitamin, multimineral is going to be good because in some cases, there's some data saying that patients can start feeling demented, memory loss, cramping, fatigue. And so a lot of it could be due to the mineral depletion. So we need to have this conversation with our patient. I added in some drug nutrient depletion. There's 3 slides on this, and then I think we're done. Loop diuretics like Lasix or Bumix, which are the most common ones, will deplete a lot more than just potassium, calcium, magnesium, B1, B6, and zinc. So you go figure, right? In potassium-sparing diuretics like triamterene or the hydrochlorothiazide, which are very commonly given. Again, calcium, folic acid, zinc, and B6. Okay, and they have quite a few problems, from osteoporosis to wound healing with the zinc, to depression with B6, and then I think the last one, or a group of diuretics, is thiazide diuretics. They will deplete CoQ10, which puts you more at risk for congestive heart failure. Magnesium, potassium, zinc. Again, zinc is slow wound healing, lower immunity. You get the point. So just as a quick review, a diuretic is a stimulant, temporarily pushes the kidney to expel more water. Really, that's all it does. Whether it's a natural one or a drug, the only thing is that the drugs, we have to learn that when we're in an acute care setting, they have significant side effects and adverse effects. And Dr. John Newstead and Jonathan Wright wrote this book. It's like $2 or $3 on one of their websites. I have no link to them at all. I bought this book not because I need to go through dialysis, but because these two are pioneers in nutritional medicine. They're both, one of them is medical doctor, Dr. Wright, out of Tahoma, but this is a fabulous, so at some point patients need to be on dialysis, and I tell you, dialysis can save lives. especially when they can't eliminate, they can't filter. Some people are going to be on dialysis for life. So sometimes, can they thrive through dialysis? Yeah, they sure can. They sure can. Hopefully, we can prevent the patients from getting through there. But again, they need to really be working with a nephrologist to look at what they should be eating, what type of lifestyles they should be having. And this little pamphlet, it's a tiny, tiny, it's not even a book, it's a little pamphlet. It's like $2, $3. Um, and it would do anything but hurt the patient. It will provide them with proper information. So that's just my little input. So that said, just load up on your lycopene. Remember, watermelon has more lycopene than tomatoes do. Choose a watermelon that has that redness in it. Interesting enough, seedless melons have more lycopene than those that have seeds. And so, as WebMD says, right, there are health benefits of watermelon. It's loaded with lycopene. It can help. The sun benefit is mostly of a protection. It has some pigments that can help you in the plant protect from the sun, but still use SPF if you're going to be out in prolonged periods of time. It protects your joints. Is heart healthy, rich in an amino acid called citrulline, which helps as well as a diuretic. So one thing that's very interesting is when you look at a lot of the data and you go to websites like WebMD, official websites like MD or PubMed, and you look at a lot of the stuff, there's a lot of information that tells us what it's good for. You just won't be seeing these type of therapies in acute or critical care setting, but as an outpatient, the patients can go and they can be informed as well. Again, I would suggest look for a primary care provider that is willing to that knows how to work with nutritional as well as well as with drugs. So that said, we're done. And have a good rest of your week.